Physicians Health Network. We're a group of physicians that are here to improve the health of people of African descent. Also, a very important aspect of what we do is to encourage young Black males to think about going into medicine. It's understood that Black males are not going into medicine at this time, and we're here to give them that encouragement that they can do it. Yes, you can be a doctor. Our webinar is every second Saturday of the month at 1 o'clock. We encourage you to tell others and join yourself. Hopefully you get medical knowledge from what we're talking about. Our webinar also can be seen on YouTube. Any prior webinar that we've done is on YouTube. So go to OBHealthy YouTube. Remember to subscribe. That way we can continue to bring these webinars to you. The most important thing that I can say today before we begin is do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you from a medical standpoint. All right. Now, I would like to introduce the doctors. Understand that there will be doctors joining. We have doctors coming in as the program goes. We will have other doctors coming in. But we're going to start with Dr. Kendall Sprott. Can you please introduce yourself?
My name is Kendall Sprott. I'm a graduate of Morehouse College in New Jersey Medical School. My specialty is pediatrics, and I did 15 years of critical care pediatrics.
All right, thank you very much. Dr. Atherley, could you introduce yourself, please?
My name is Trevor Atherley. I'm a board-certified cardiologist. My subspecialty is interventional cardiology. I practice mainly in Essex County, and I'm based at Newark Beth-Israel Medical Center.
All righty. And Dr. Kevin Clark.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I practice at Newark Beth-Israel Medical Center.
All right. And Dr. James Court, please. Dr. Court, can you hear us? I know we were having some technical difficulties with Dr. Court, and hopefully we can resolve them soon. All right. Dr. Court, can you hear us? All right, we'll resolve that. We have the technician working on it. All right, thank you. Thank you for joining us today. We're going to get started here. And I would just like to say that today we're going to talk about cardiology and how it relates to other organs, other diseases. And it's so important because the heart is such an important aspect of the body and how it works and how other organs are able to work. If the heart is working well, then we are working well. And that's one of the things that we should understand. We have to protect that organ and how that organ relates to others. All right. So I'd just like to start off with something, and we all know that, and here's a question that came in. Let me do it that way. How can you prevent strokes? All right. I have frequent episodes of dizziness. What can I do? Is this dangerous? And it's a question that comes about often because strokes is something that's very common, believe it or not. And we should understand how the heart relates to strokes. Dr. Atherley, can you start off just a little bit and we'll chime in as far as strokes are concerned? I'll take it from pulmonary and maybe Dr. Sprott can talk about internal medicine aspects and Kevin can talk from a surgical aspect. Can you start us off with strokes?
Stroke occurs as a consequence of impairment of the blood supply to the brain. The manifestations most commonly relate to weakness, sometimes loss of consciousness, but weakness in particular areas, particular limbs and parts of the body. Speech may be affected, consciousness may be affected, but predominantly we see weakness of upper or lower extremities, some facial contortion sometimes. Now, from the cardiac viewpoint, there are a few ways in which the heart may be related. Firstly, I think there is the commonality of the basic processes that may occur. With the heart, one may see partial blockage of the arteries to the heart, a process called atherosclerosis. These coronary arteries run on the surface of the heart, providing the heart with the blood supply so that it can function effectively as a muscle. Well, there are arteries throughout the body, When the arteries to the brain are affected, such that there is diminished blood supply to one or more areas, then this may indeed give rise to the weakness that we describe as a stroke. So some of the commonalities, some of the same underlying problems may occur as a consequence of the atherosclerosis or deposit of fat into the arteries. There are other methodologies by which these arteries may become blocked. Another one from the cardiac viewpoint is called embolism. That is, blood clots or infectious material within the heart may travel through the bloodstream and end up in the brain. And when they do, if they block significant arteries in the brain, then the area of muscle that is supplied by those arteries that are blocked now has a deficit. And that deficit may be manifested by weakness or other specific symptoms. So there are some commonalities with the heart, and some of the factors that affect the heart can also affect the brain. Another important aspect of heart and brain may relate to arrhythmias or irregular heartbeats. Sometimes one may be subject to irregular heartbeats, and the commonest of which is called atrial fibrillation. That's a kind of rapid heartbeat of the smaller chambers of the heart, and the heart may beat erratically, and when it does, then it does not supply blood appropriately as it should to other parts of the body. Again, a manifestation in the brain may be the episode of fainting or passing out, or even just dizziness. So I'm not sure if others want to talk about strokes first, and then I can go on to talk about the wider concept of dizziness, but I'll leave it open to others to talk about strokes if they like. Kenny?
Yeah.
Well, you know, I think that as Trevor pointed out, the manifestations of stroke are really related to injury of the brain, primarily due to lack of oxygen. And he talked primarily about some of the things that can cause lack of oxygen to the brain. There are certain other things that can give you the same manifestations that might relate to decreased oxygenation or oxygen supply to the brain. I mean, you can have a bleed, and some people might have a weakening of the vessel wall that might break, and they call that an aneurysm. And if that breaks, that might lead to lack of oxygen to the part of the brain, and lead to the manifestations of stroke. And depending upon where you actually have the stroke, that part of the brain that controls either motor function, right side of the body or left side of the body, once that part of the brain is damaged, then you'll start to have those manifestations. You can have other areas of the brain that could also be affected. And so if it deals with the part that deals with your smell or some of your other senses, you might lose those kinds of functions if you have those kinds of things. And certainly if you have traumatic brain injury, if you get hit by a bat or you hit your head, the same type of symptoms might occur because of damage to the brain and lack of oxygen. And I know that we're going to talk about dizziness, and dizziness is something that again may be related to lack of oxygen, and the lack of oxygen could be related to a low blood pressure. And sometimes that might be positional. Some people, if they're laying down for a while and they get up too soon, a lot of the blood that's pooled in the vessels, if you get up too rapidly, you might feel like as if you're dizzy. One of the other issues that has to do with how you see yourself or position in the world, in the world in terms of your balance and equilibrium, has to do with your inner ears. There are three small canals that are sort of in 90-degree angles, and there's fluid going through them. And sometimes if you have blockage of the fluid or damage to those inner ears, you might have issues where you become dizzy. And it might be related to a sensation of the room spinning, which is something called vertigo. So I think that a lot of the issues related to stroke, to a certain extent, depend upon underlying conditions. It could be heart disease, it could be diabetes that affects things, and certainly the things that we talked about in terms of trauma. And a lot of these things are somewhat age related. And so the older you get, the more prone you are to have those kinds of things. It's not as if younger folks can't have them, and certainly they can, but it's much more likely to increase with age and conditions like hypertension and diabetes.
Yeah, that's so true. As far as hypertension, that's one of the things that in our communities, it's a very great problem. Increasing the blood pressure is definitely one of those diseases that increases your risk for stroke and the severity of stroke. Number two is that you had talked about stroke and some of the decrease or failing or functions that will stop being available for you. Things like speech, things like being able to swallow, your mentition, being able to think, being able to have strength in your arms and your legs. All of these can come about, and as you stated, it depends on where in the brain the stroke occurs. Now, also, the good thing about it is that with rehab, sometimes you can get dysfunction back with appropriate rehab. And that's one of the godsends as far as stroke is concerned. Not necessarily will all of it come back, though. You can rehab to a certain degree. Sometimes people have permanent dysfunction. Also, there is stroke, and then there are what we call mini strokes. A mini stroke is you get that dysfunction, whatever it is, of speech or a decreased ability to have strength in your arms or legs, and it only lasts for a short time. That is called a mini stroke. But when you have a true stroke, those dysfunctions last for some time, and you have to rehab to try to get that function back. Anyone else want to chime in on this?
Just one thing. When we talk about lack of blood supply, there's a term called ischemia, which means that there's a decreased blood supply, which results in decreased oxygen because the oxygen flows through the blood. Very often, if you have ischemia, depending upon where the lack of blood supply is, there's pain associated with it. The brain is an unusual organ. It's the most probably important organ. I mean, Trevor may disagree that the heart, but the brain is the key to everything. And so in many respects, the heart is responsible for pumping blood, which carries oxygen to all of the organs within the body. But unlike other organs, if the brain has ischemia or decreased blood supply, before the cells actually have been deprived enough to die, there may be ischemia, and there won't be symptoms necessarily of pain, but you might have these symptoms of weakness or not being able to speak or things like Omar talked about. But ischemia is where you have decreased blood supply, and it could be to a part of the gut. It could be, for an ovary. If the ovary, which is on a pedicle or stalk, if that twists and you cut off the blood supply, there'll be intense pain associated with it. And if you can relieve that, same thing with the heart. If you can relieve that ischemia, restore blood supply, then the pain will go away.
Excellent.
Yeah, while we're talking about hypertension, there's
Doctor, please, what I was going to do is give me 1 second and don't forget that thought. I want you to introduce yourself, please.
Yes. Hi, everyone. It's Dr. Anderson. I'm a GYN oncologist. I work at Newark Beth Israel. Okay. And I'm with the Physicians Health Network. It's always an honor to be here.
All right. And Dr. Court, do you hear us, Dr. Court?
I can hear you now.
All righty, good. Can you introduce yourself, please?
My name is Dr. James Court. I'm an internal medicine doctor. I practice in East Orange, New Jersey. And I'm quite familiar with all of these guys.
All right, thank you very much. Dr. Anderson, take it away.
Yes, I was going to make mention of the issue with hypertension and chronic hypertension and some of the damage that it can do. Physiologically, when you look at the basic vasculature of blood going into an organ system, there's usually some collateral or alternate blood supply, and it allows the blood to go in and out or collaborate with blood flow from other areas. And there are these organs that are called end organs, which just has one blood flow in and the venous out. The eye is one of those. In men, the penis is one of those. So with chronic hypertension, when the constant pressure damage the microvasculature or the tiny vessels, these organs can become irreparably damaged. So hypertension, the eye, sexual dysfunction is one of those things too that, you know, can be affected by chronic hypertension.
Very good, very good. Doctor, I'm going to ask Dr. Clark, as far as brain function is concerned, when you're taking patients into surgery, and if they're per se, if they're not alert or awake, or is that something that's concerning as far as the brain function when you evaluate patients going into surgery? For instance, they've had a stroke and they may have, that if the vessels of the brain are affected to the point where the patient had a stroke, would you be worried about other vessels in the body and when you're taking the patient to surgery?
Absolutely. I think one of the things we'll get into it later on, but I think a global evaluation of a patient's status and their appropriateness for surgery is one of the initial things that we figure out. The first thing we do is the operation that we're thinking about indicated. That's the very first decision. And is it an elective or an emergent situation that we have to undertake? In evaluating patients, that's one of the many things that we look at. So their neurologic status and their mentation, whether or not they've had previous strokes, whether or not they're demented, all these things play a role. Now, we were talking about strokes and the different ways that you can get brain damage. So you can get it, as Dr. Atherley mentioned, from a lack of blood supply. And one of the things that we do in surgery is that we can correct that. There's a procedure where you can restore blood flow to the vessels going to the brain, called an endarterectomy. The other way, you can have an embolic stroke or you can have a hemorrhagic stroke. But these are all things that we look at.
Could you explain those? Embolic and a hemorrhagic. Those are words some people may not understand.
So embolic, as Dr. Atherley had mentioned, there's a condition in the heart which is atrial fibrillation, and I'm going to let Dr. Atherley explain that one, where clots form in the heart because it doesn't pump appropriately. A portion of that clot can embolize, what we call travel from the heart into that blood vessel and occlude it. And when that happens, it prevents blood from going to the brain, and that can cause damage in the consequences of what we see as a stroke. Other areas, you can have a hemorrhagic stroke where you can have small areas in the brain where the blood vessels are delicate and it can actually burst. And in that situation, you have an impairment both in the supply to that area, because now it's not being delivered appropriately. And anytime blood is in the brain in that area, it causes a reaction. So those two things can, again, manifest in the things that we spoke about as a stroke.
All right, excellent. We have several questions that's come up. One of the questions is, what can I do to avoid a stroke? Dr. Sprock, can you start us off with that? And there's another question that's directly to you, Dr. Sprock. It asks to explain a lacunar stroke, if possible.
I'm not a expert in neurology, but let me say this. I think that the issue of trying to prevent yourself from having a stroke really has to do with if you have underlying conditions that contribute towards a stroke, you need to manage those conditions. And so, hypertension, when you think about, well, what's the definition of hypertension? You say it's high blood pressure. Well, there are three components to the blood pressure. One has to do with the fact that the heart, which is pumping, has a certain amount of force that it creates when it contracts, and it pushes the blood through. And then the others has to do with what's in the blood vessels. Remember that the blood vessels three really types of blood vessels. That are arteries that carry the blood and the oxygen to the tissue. They're the capillaries that are the space in between the arteries and the veins carry the blood back to the heart. Now, a minute ago, we talked about clots. Clots are something that usually tend to form when the blood flow is low. And so most of the clots that tend to form in the venous system. And then if those clots break off, when they come back to the heart, they have to go through the lungs. And very often the lungs trap the clots, and you can have what's called a pulmonary embolism. If there are issues with bad valves, you might have things that happen and grow on the valves. And if they break off, they go to the brain, which can give you the strokes. But hypertension is something that if you can control, you might be able to help prevent yourself from having a stroke. Now, when we talk about the heart, again, the heart is a muscle. And when you think about it, if you're trying to build muscles, and what you do is you can do exercise using weights. And the more weights you use, the more muscles you will build, because there's in order to build up muscle, the fibers of the muscles have to break and rebuild. When they rebuild, they get bigger. Now, there are muscles that line the blood vessels. And if the blood pressure is elevated, then very often those muscles that surround the arteries can get bigger. And that means that those blood vessels may get narrower. And when the heart pumps, the heart has to work harder to pump the blood. And then the heart, which is a muscle, also gets bigger. And so if you see that you're starting to have high blood pressure, one of the things that the cardiologist may do is sort of examine the heart with something called ultrasound, where they can measure the actual thickness of the muscular parts of the heart that contract. And if that is happening, if that heart is getting bigger, that's an indication that you have significant hypertension, and you may be predisposed to having a stroke. And so the idea of, if you have hypertension, that hypertension needs to be managed. And the management is either to take a medication that might prevent the heart from contracting so much, like a beta blocker, they call it. Beta. Trevor can explain that a little bit better. Or a diuretic, which reduces some of the volume of the blood, the liquid part, not the cells, not the red blood cells or white cells. And then the other thing is to sort of relax those muscles that surround the vessels. And so if someone has hypertension, they're taking a medication or more than one medication that affects either the blood volume, reducing the blood volume, which will reduce the pressure, giving something that prevents the heart from contracting as forcefully, like a beta blocker, or giving something that causes the blood vessels to relax, and in relaxing the diameter of the arteries gets a little bit bigger, and the pressure goes down. It's sort of if you think about hypertension, hypotension, where there's decreased blood supply, can occur from same thing. The heart isn't beating so forcefully. You could have damage to the heart, or there's a relaxation of the blood vessels, or there's too little volume within there, either from a bleed, if you're bleeding out. So the treatment for hypotension is to give something that's going to cause the blood vessels to tighten up. You give something like volume, either fluids or blood, or you give something to stimulate the heart to make it contract forcefully. Now, diabetes, which again causes a lot of damage because of damage to small blood vessels. If you have diabetes predisposes you to both heart attacks as well as strokes. If you manage the diabetes, you may be able to decrease the possibility of your having a stroke. So I think the most important thing is to understand and work with your doctors that if you have underlying conditions like diabetes or hypertension, which are very, very common, especially in African Americans, that if you manage those, you might be able to decrease the incidence. And the other thing, if you happen to be a smoker, the tobacco, that nicotine is not good for you. And if you stop smoking, you can also decrease some of the risk associated with these things. And especially if you have all three. If you're a smoker, if you have diabetes and hypertension, you're really a setup. And so you need to take responsibility for trying to manage these conditions, which are chronic conditions, in order to prevent yourself from having a stroke.
True. And I think, go ahead. I'm sorry.
I was going to sort of amplify a bit on what Dr. Sprott so excellently alluded to. I think that it is important that if you understand the factors that can give rise to strokes, that if you have any of these present, that you control them. So these are the so-called risk factors. While there may be a genetic component, one is worried about components that you can't affect. High blood pressure, as dealt with by Dr. Sprott, is an important one, and it behoves you to control the blood pressure as best you can. The first aspect of the control that we try to observe is dietary restriction. And we're aware of the role of sodium or salt in increasing the volume of blood that is circulating. And hence this increased volume may be associated with high pressures within that vasculature or within the blood vessels. And these can be deleterious to many organ systems, including the brain. But there are other risk factors that we should be aware of, and diabetes was mentioned. There's clearly a relationship between the occurrence of diabetes, the control of diabetes, and the complications of diabetes. So what we try to do is to control the blood sugars. Since you all know, of course, that diabetes is a manifestation or is a disease that occurs as a consequence of elevated blood sugars. We try to control these. We look at other factors. Cholesterol is one of the things that has been associated with tendency of these arteries to have narrowing as a consequence of deposition of the cholesterol into the wall of these arteries. And narrowing of the arteries can cause the pressure to rise. So that is another one of the major factors that may contribute. Now, you mentioned the factors that we can do to diminish the occurrence of strokes. It's the same sort of factors that we use to diminish the occurrence of heart attacks. As you know, heart attacks occur. Heart attacks are something like a stroke of the heart, if you want to put it that way. The same sort of problems that can occur in narrowing of the arteries and diminishing the blood supply to the brain. When the blood supply to the heart is diminished, this can cause heart attacks. Maybe we have a better handle on how to treating the heart attacks, I suppose, because of the accessibility. But the manifestation of narrowed arteries to the heart can be, before the actual heart attack, can be pains. One may have the warning pains of angina pectoris. These pains, when properly described and assessed by the physician, may be a clue to the existence of narrowing of those arteries. And then one may then be able to get in and take care of the narrowings by interventions and putting tubes and dilating those arteries in the areas there are, and put stents. We can talk about those at another time. Okay, or medication, which will help restore the balance between the amount of blood the heart is getting and the work the heart is doing, which demands a certain amount of blood. So we try to restore a little balance there to cut down on those pains that occur. And of course, the ultimate is a heart attack, whereby a sudden rupture of the walls of the arteries or of an artery to the heart, there is formed a clot in that artery, which immediately cuts off the blood supply beyond the clot. And so with these heart attacks, we have a limited time in which to go in and do certain procedures to restore blood flow to those areas. Otherwise, the muscle of the heart will be irreversibly damaged, causing a heart attack. And then one can treat in other ways, but we'll never be able to restore that muscle to good function again if a full and permanent heart attack has occurred. Right. But these are strokes of the heart, and strokes of the brain were our major topic. So my bottom line really would be to identify the risk factors which are present and try to control these risk factors. And there are a few more that we can talk on, but I'm sure that some of the others may want to add to that.
I just wanted to add one other thing as it relates to what you might do to try and help improve both the hypertension and diabetes. And Omar, you can talk about the diet, but I think that one of the most important things that you can do, and as we get older, we tend to lose muscle mass, but exercise is a very important aspect of what you might do to help improve both hypertension and diabetes. You know, one of the things that is important as you get older is to try and control your weight. And there's a big association with being overweight or obese. and having diabetes. And so to help combat that or to reverse some of the issues related to diabetes, it's important for you to lose weight. And you can lose weight by either altering your diet, reducing your calories that you take in, and, or burning up calories more, which is exercise. Now, the most efficient way to lose weight is to reduce your calorie intake. Exercise can do it, but it's not going to dramatically decrease your weight. But what becomes important, especially as you get older with your exercise, is that you exercise to get your heart to work. And there's something that's called your maximal heart rate. And there's this rule of thumb. It's like 220 minus your age. I have a birthday coming up. I'm going to be 70 on December 5th. And so my maximal heart rate is around 150. And so one of the goals for me is to do an exercise so I can get my heart rate up to 150. And I do something called high intensity interval training. So I get my heart rate up by exercising vigorously as much as I can for 30 seconds and then do a little relaxation. But exercise can improve your life. It will improve your strength. So, you know, one of the things that tends to happen as you get older is you tend to fall. You can help to improve your balance and your flexibility. So I think that if you combines the diet, which I think is primary, along with some sort of exercise, and you can talk to your doctor about coming up with exercise regimen that will increase your aerobics, which means that you're consuming a lot more oxygen in that kind of exercise, or your strength. And you don't have to go out and try and do it all at once. You do it gradually. It can be an important component to increasing your life expectancy, as well as help to control some of these things like diabetes and hypertension.
And you know, walking is one of the best exercises. And you don't have to go to the gym and work out with the heavy weights and all of that. Just getting up, walking on a consistent basis, a half an hour a morning, 15 minutes each morning works wonders. And let me just talk about also weight loss is so important. And Dr. Sprock, you alluded to it, that there are so many of us, especially in the African-American culture, that are overweight or obese. And weight loss is a key to decreasing hypertension, diabetes, and preventing strokes. Decreasing stress. Stress is a major component that we have to learn to decrease. You know, we think about mind, body, and how it relates, but stress is something that we need to understand. It can cause havoc as far as the body and your health is concerned. So learning how to decrease stress is very important. Decreasing sodium or salt on your food can definitely be one of the primary items that can improve, you know, your health as far as your heart is concerned, and retaining fluid and decreasing your blood pressure. And also, if you have a history of diabetes, then you have to follow your physician and follow your hemoglobin A1C. Where that particular value is gives you an understanding of how about your blood sugar over like a 3-month period, to let you know if you're in a decent range as far as your blood pressure, blood sugar is concerned. And also better nutrition. You know, going out to fast food restaurants every night, believe me, I understand that they try to make healthy meals, but guess what? You know, to a certain degree, it comes down to making money, and there's no way that they can give you a healthy meal for the price that they're giving you the meal for. So what I would say is that at this particular point, just think about overall health, some of the things that, you know, that your doctor may be telling you, and try to institute some of those things so we can decrease this problem, hypertension, diabetes, heart disease, and stroke.
And it's important to mention these as a problem because they're so often associated together, forming one major problem. We look at the multiplicity, the number of risk factors that you have, and your risk of getting heart disease or strokes increases significantly based upon the number of these risk factors that you have present. So they all seem to interplay with each other. I mean, we talk about exercise and the relationship to obesity and hypertension and diabetes, etc. So correcting one can help in improving the other. Now, the role of exercise has been well studied over the years, and the lack of exercise has been clearly shown in a variety of of studies and publications has been shown to be related to heart disease, especially coronary artery disease, the lack of exercise. We've struggled for a while in terms of, well, how do we remedy this and what exercise is required? Turns out that the high intensity, I'm glad that Dr. Sprott is keeping young with those, exercises may not be as necessary as just moderate, regular exercise. And I would recommend to most patients, especially those who may have some underlying disease, that they assume gradual increasing amounts of exercise, but attaining moderate exercise and at frequent intervals. It is not enough to do exercise 1 day of the week and consider that sufficient. I advise at least 3 to 4 days, if not 5 days a week, 3 to 4 days of the week that you perform moderate level exercises, and that the exercise be done with proper warm up and cool down exercises before you do your maximum exercise. And especially don't exercise immediately after meals, allow an hour or so before you go into your exercise program. So proper exercise, aerobic type exercises are important. Exercises help in muscle toning and they help to build muscle. I just want to add one caution in terms of heart muscle. While we like to have strong hearts and healthy hearts, too much muscle is known as hypertrophy. And hypertrophy or excessive muscle in the heart is actually a disease, especially of the powerful pumping chamber called the left ventricle. So if the heart muscle becomes too thickened from overwork, that overwork can be caused by high blood pressure and a few other situations. If the heart muscle becomes too thickened, then it becomes inefficient and may be a source of disease and failure of the actual heart muscle. So just be careful with the heart and the amount of muscle that you build up in the heart.
Excellent.
Yeah, so, I know we're talking about blood pressure and the influence on the heart and the brain, but some of the risk reduction activities requires exercise. And we know that chronic hypertension not only affects the heart and the brain, but also the muscles of the extremities, which is needed for proper and adequate exercise. So sometimes when folks stand a long time and they walk a long time, they get calf pain, something that we call claudication, which is somewhat an indication of poor circulation to the extremities. And we need healthy blood vessels to prevent muscle atrophy or reduction in the size of the muscle, which ultimately can affect your ability to do exercise and sometimes can get so bad that it causes ulcers that requires wound management and sometimes amputation. So globally, the expanse of the effect of poor control of blood pressure, it touches every part of the body in any and every which way it will.
Excellent, excellent.
So Omar, there's the question about the lacunar strokes.
Yeah, lacunar infarct, yeah.
Yeah, when we talked earlier about the issue of ischemia, which is a decreased blood supply. And that's one of the ways that you can get a stroke. And that stroke is technically the result of an infarct or like a myocardial infarction. It's where that tissue actually dies. The same thing happens in the brain. You can have infarction where the brain tissue dies. Well, these lacunar strokes are really very tiny strokes. A small vessel is involved that is responsible for the stroke. And because I think that Patrick talked about or Kevin talked about the fact that sometimes there are collateral blood vessels that are there. Because it's such a small vessel, there may be other vessels in the area that might help with the recovery of those types of infarct. But statistically, they say that maybe a quarter of all these ischemic types of strokes are due to these small, tiny blood vessels, and they call those lacunar strokes.
Yes.
I just have a comment in
Yes,
terms of importance of exercise. I sometimes demonstrate to my patients that you can exercise every day. It doesn't have to be in the summer. You can also exercise in the wintertime. And once you're not homeless, if you walk back and forth in your house on an area that's free of furniture, you can do it every day. You can go back and forth for 30 minutes, just the same as you can do it outside. So you don't have to be faced with the elements or possibility of being robbed or anything else. So exercise is important, and it can be done every day.
Mhm. True, true. I think that it's more effective when you do it every day, and that's for sure. I think Dr. Atherley alluded to that. Let's go on to another topic. And it's an OBGYN topic. And Patrick, you can maybe start this off, but I think we can all chime in. I have a heart murmur. Can I get pregnant safely? Number one. And how is the heart affected by pregnancy? Okay, so we're talking about the heart, but it's the overall theme is pregnancy and your heart. Patrick, can you start us off a little bit?
Yes, and Dr. Atherley will help me out when it gets a little bit technical. But during pregnancy, there's a lot of physiologic changes that occurs, and a lot of it has to do with changes in hormones that enables the body to accommodate and relax to allow the pregnancy to develop. And for a pregnancy to develop, the uterus has got to have the ability to grow. In order to do that, there are certain hormones like progesterone, which causes muscle relaxation, and that it softens the uterus and allows it to expand with as little restriction as to the content of the uterus as possible. Now, with the elevation in these hormones, it also affects other parts of the body that has smooth muscle, of which the heart has smooth muscle. The advantage there is during pregnancy, the heart has the ability to expand because in order to accommodate good oxygenation from the maternal circulation to the placenta, the blood volume also increases, which is the amount of blood that now actually goes into the circulation. In order for that to happen physiologically, without your normal adjustment, your blood pressure would go up. So by causing these smooth muscle in the blood vessels to relax, it allows blood vessels to relax to accommodate the increase in volume. And as part of the circulation, the heart is one such organ that needs to be able to tolerate the increase in blood volume. So with respect to blood pressure, pregnancy is one of those conditions where physiologically it's almost a physiologic increase in blood pressure. Now, when that blood pressure gets too high, and some of the risk factors of that is in young women with hypertension or chronic hypertension, when they become pregnant, that increased volume now adds to the stress on the vasculature. And when that blood pressure gets too high, women develop what we call preeclampsia, which is severely high blood pressure, which can affect the kidneys. They spill protein in the urine. And some of these women can become eclamptic, where they can actually develop seizures during pregnancy. One of the conditions that is peripartum that we talk about is a cardiac myopathy or weakening of the heart muscle. The full physiologic breakdown
Patrick,
of that.
what's peripartum?
That time period surrounding the pregnancy, either just before, during, or right after the pregnancy, right after delivery. So the heart muscle can become weak. It usually is temporary or transient, but once all the hormonal changes occur and patients achieve full equilibrium, most of the times the heart will return to normal function, but it usually doesn't happen without help from the likes of Dr. Atherley, because sometimes medication has to be implemented in order to get the heart to function until the body equilibrates. You lose the extra volume, you decrease what we call the preload or the force of which the heart has to pump against as a result of this extra volume.
You know, the question had to deal with murmurs and you know, a murmur is a sound that you don't normally hear that comes from the heart. In pediatrics, we have a number of children that have heart murmurs, and very often there's nothing abnormal with the heart. They call it an innocent murmur. And so, but if the murmur happens to be caused by a problem within the heart, either something with the valves where they're tight or they're relaxing, or if there are holes in the chambers of the heart. There can be an abnormal problem that's going on with blood flow. And in general, most people that have murmurs are referred to a cardiologist unless the pediatrician knows that it's an innocent murmur. And then the cardiologist will try and determine what's causing the murmur. And depending upon what's causing the murmur, there may need to be management issues related to the pregnancy. But Trevor, you can express what goes on with.
Yeah, and I think sometimes the murmur in pregnancy has to do with, one, the increase in blood volume, two.
Well, but you were talking about before she got pregnant, you know.
Oh, right. So and sometimes these murmurs before they get pregnant, sometimes some of these murmurs are due to what we call prolapse, we don't often know initially, or sometimes they have what we call leaky valves. And during pregnancy, with the increased blood volume and the increased relaxation of these muscle strands that actually control the valves, sometimes these valves become less functional. And again, Dr. Atherley can expand on how some of these murmurs, depending on the duration, the length, where in the phase of the contraction the murmurs occur, can give us a good idea as to what type of insult there is to the valve.
You know, Dr. Atherley, if before you start, and segue, I know we're dumping all of this on you, but okay. In segueing into that, we just had a question about mitral valve prolapse. And the question refers to pulmonary embolus. Well, we'll get to that, but maybe you can just, they wanted to know what was mitral valve prolapse, since you brought it up, Patrick.
Let me try to handle a few of these questions. Firstly is what happens to the normal heart versus the diseased heart, okay? And I think that Patrick did an excellent job in explaining the physiology of how the heart responds, especially with the increased volume that occurs late in the pregnancy. And in a normal heart, it usually does not cause much of a problem. Now, we have seen normal hearts where post-pregnancy or in the peripartum period, the heart has become weakened and not functioning adequately, and patients have what may be called congestive heart failure as a consequence of a peripartum cardiomyopathy. These patients do not necessarily demonstrate significant abnormalities of the heart before, and many of these have apparently normal hearts. We know that may not necessarily be true, but there was no manifestation before. So at times we're concerned about the effect that the pregnancy may have in a small number of normal hearts, but we are much more concerned about the effects of the pregnancy in patients who have diseased hearts. Now, the question related to someone having a murmur, and murmurs, as was alluded to by Kenny, murmurs are sounds that are unusual and that may occur just from the amount of blood flow and can be described according to the location in the cardiac cycle. As we listen to the heart, you know, they will lub dub, the two sounds. Well, in between those is the most common area in which you may hear the heart murmur, lub, dub, something like that, as I tell my students. Anyway, so those kind of murmurs we can sometimes discern merely from the way it sounds as to whether it is serious or not. We listen to what part of the chest it is heard loudest. We listen to the actual character of the murmur, and we can determine sometimes merely from listening. Many times, however, we are required to do some tests to objectively describe the cause of the murmur. I will talk about mitral valve prolapse as one of the commoner murmurs and commoner cardiac situations in a moment. What we fear, however, is where valves of the heart or congenital, that is diseases that you're born with, are dependent upon the flow and are affected by the flow either through these valves or holes, and the volume of blood that is circulating may adversely affect that. So in pregnancy, when we have an increased amount of blood volume, it can worsen some of these effects, which may not have been known before. A classical one is mitral valve stenosis, for example, where some patients who've had these sort of problems with narrowed valves, suddenly these come to the fore and we become aware of them during the course of pregnancy. So pregnancy may open our eyes to the existence of previously not diagnosed heart disease. And then we have the onus of how to treat this. At times, the the situation may be so significantly impaired that we may have to advise or request of the obstetrician that the period of delivery be shortened. We may have to discuss the kind of delivery, whether natural or whether there has to be a C-section or some other form, because of the concern that we have of the adverse effect on the patient's mother. In fact, I've had the opposite happen, of course. I've had where the child had a significant cardiac abnormality. There was a very, very interesting situation where I had to give the mother a very large amount of medication that we would not normally give, much higher than we'd normally give to the adult, because we wanted this medication to go through the placenta and to get to the baby and control those irregular beats, which the baby documented, which were documented in the baby. So there is, it's a back and forth situation. Now, the question of mitral valve prolapse may be relevant here because mitral valve prolapse is something that has been described in younger females, 20 to 40 age group. And at one time we thought it was a severe problem, but as we look more closely at it, we found that we overdiagnosed this mitral valve prolapse. So there may be people walking around with a diagnosis of mitral valve prolapse who may think that the situation is much worse than it actually is. What that describes is the role of opening and closure of the mitral valve. The mitral valve is one of the valves which directs flow on the left side from one of the tiny, small chambers on the left atrium it is called, into the ventricles, left ventricle. And as you know, valves, the purpose of the valves in the heart is to direct flow, to open so that blood can go forward properly, and to close to prevent backward flow of the valve. In mitral valve prolapse, that valve just moves excessively. It may or may not be associated with a leak, but it moves excessively. It prolapses. It goes forward a little bit more than one might normally anticipate. Sometimes it actually leaks, and that is called mitral insufficiency or regurgitation, where the valve then not only moves excessively, prolapsing, but it may actually leak. Most times we don't have to treat these patients. Sometimes, however, there are symptoms associated with mitral valve prolapse: pain, worsening shortness of breath, fatigue, dizziness, etc. And if we can relate these symptoms, because there are a lot of nebulous symptoms, if we can relate these symptoms to the actual diagnosis of mitral valve prolapse, then we may be forced into treating the patient medically. There are rare instances where the mitral valve prolapse becomes so severe that the leakage causes the patient enough problems that we have to go and repair the valve surgically. Fortunately, we now have lesser invasive means of fixing the valves without having to open the chest. We can now fix the mitral valve by some lesser procedures, merely passing tubes, etc., through the vein and arteries in the heart to the heart. But that's another newer way of treating. Essentially, however, we only recommend surgery if the mitral valve prolapse is associated with significant leakage of that mitral valve.
Dr. Atherley, are there any heart conditions that are absolutely contraindicated in pregnancy?
Well, heart conditions where pregnancy may be contraindicated. Yes, I think first of all, we like to warn people who've had peripartum cardiomyopathy, and many of them will recover. Some will continue to have congestive heart failure or weakness of the heart, a small percentage. But we warn those that if you did have it once with one pregnancy, that the chances are significantly higher that with future pregnancies, you may again have a recurrence of that. So that may be one of the situations in which we warn patients. But there are some diseases, especially some of the more severe congenital heart diseases, that is diseases that you're born with, some of the holes in the heart, some abnormalities of the valves, abnormalities of the chambers. You may have one chamber missing, etc., where we choose to advise the patients not to have a pregnancy because the stress and strain on the heart may be such as to overwhelm the patient. You might advise such patients to have surgery before having pregnancies or not to have pregnancies at all. But there are some diseases, and I think especially of some of the more severe congenital diseases where one would, yes, say you should not get pregnant.
Yeah, some of the other ones.
Explain the cardiomyopathy you mentioned.
Yeah, so some of the other ones, just to dovetail on the last question.
There are a few others that we may cause as well. If I may interrupt for just a moment, Patrick. We question some of the valve replacements, for example, and we advise women of childbearing age to determine whether or not they want to have future pregnancies, and we talk to them about the medication that may be required and what effect that might have on the pregnancy. So women within the childbearing age who've had heart surgery with replacement of valves, we sometimes advise the kind of valve that might be appropriate, more appropriate for them. And it often is a vexing question. When we replace the valves, we have some valves which are known to last for a very long time. They don't degenerate or break down as easily. They last for a very long time. But those long-lasting valves, unfortunately, are the ones for which the patient requires blood thinners. And blood thinners, you know, may have an adverse effect on the fetus, the developing fetus, and certainly at the time of delivery, there may be problems with bleeding, etc. So we'd have to adjust medications significantly if we allowed such patients to become pregnant. Instead, one of the choices that some young women request and that we offer is a valve, a tissue valve, a valve made of tissue material, whether it's pig valve or the lining, the outside of the heart of a cow's valve, etc., cow's heart. There are some tissue valves which we can use, and the advantage being that these patients will not require to have the blood thinners or anticoagulation, these blood thinners for a long period of time, and will be able to have the valve function adequately without the need for the blood thinners. The disadvantage is that these valves are not as durable. They don't last as long as the ones that are made of the totally artificial material. And so it's a matter of weighing up the pros and the cons. If the young female patient wants to become pregnant, that it may be a vexing and difficult decision to be made between the patient herself and her physician as to what kind of valve to use in the event that she becomes pregnant.
Right.
You had a specific question?
Yeah. Now, I know we talk about valves, but what we haven't done is explain the different type of valves and how they function, because the different type of valves does influence whether we counsel someone to get pregnant or not. So, for example, the aortic valve, which remind me, Dr. Atherley, I break hearts, I don't really fix them. The aortic valve is that valve between the left ventricle and the aorta that opens and closes to allow blood to leave the heart to the rest of the body. Now, when we have that condition called aortic stenosis, that can be catastrophic, because now when you add the increased volume of blood and the additional work that's required to pump through a narrow or a stenotic opening, that could have a serious effect on the heart as the pregnancy develops. And you can come in on that and help me out with that one, Dr. Atherley. The other one that comes Dr. Bay's way is we often counsel women who are diagnosed with pulmonary hypertension or elevated blood pressure on the right side of the heart. And if Dr. Atherley and Dr. Bay could talk about how, you know, the blood pressure that we so often talk about is the blood pressure or the force that the heart experiences pumping blood to the body in general. But just remember, the other function of the heart is to pump blood to the lungs to allow it to be oxygenated. You can also have elevated blood pressure on that side of the circulation as well. And we call that pulmonary or right heart hypertension, or, you know, and just the way, same thing with heart failure. The heart failure that we commonly talk about is heart failure on the left side, but you can also have a right-sided heart failure. If Dr. Bay and Dr. Atherley can talk about that a bit.
Yeah, that's excellent, Patrick. What I'm going to do, though, is we're going to come back to that because it's halftime for us, and I just like to, and also just to note, we'll go to those two topics, but also we got some excellent questions coming in that I'd like to address as well. And you may hear some noise in the background. Believe it or not, where we are, there's a tremendous thunderstorm. So hopefully our connection stays positive already. For those that joined us late, well, we are Physicians Health Network, and thank you for allowing us to bring this webinar to you. What I'd like to do is reintroduce our doctors, because you may have come in and did not have a chance to hear who they were or who they are. Dr. Kendall Sprott, could you introduce yourself, please?
My name is Kendall Sprott. I'm a graduate of Morehouse College in New Jersey Medical School. My specialty is pediatrics, general pediatrics, and critical care pediatrics.
All right, thank you. And Dr. Atherley, please.
Yes, I'm Trevor Atherley. I'm a cardiologist. My subspecialty is interventional cardiology. I practice in the Essex County area, and my main office is in Newark Beth Israel Medical Center.
All righty. Dr. Kevin Clark.
Hey, good afternoon. Thank you for having me. I'm a surgical oncologist working at Newark Beth Israel.
All righty. And Dr. Patrick Anderson.
Yes, I'm Patrick Anderson. I'm a gynecologic oncologist. I take care of women's cancer, graduate of Rutgers Newark, graduate of University of Medicine and Dentistry in New Jersey. Every single person, well, except for Dr. Clark on this panel, has had something to do with my growth and development, both Dr. Sprott, Dr. Court, Dr. Atherley, Dr. Bay, and Dr. Clark is my esteemed colleague. We work side by side every single day.
I'd just like to add that I had nothing to do with your history of breaking hearts.
and Dr. I like that. And Dr. James Court, Dr. Court, you should have added your little helper there. Very cute.
Yeah, I know.
I must admit, you should have held on to that helper.
That's my daughter's cat. Wants to be involved in everything. Dr. James Court, internal medicine, graduate of Howard University School of Medicine.
All righty. And as usual, I forget to introduce myself. I'm Dr. Omar Bey. I'm a pulmonary critical care physician and a subspecialty in nutrition. I'm Director of Nutritional Support for the ICU at Beth Israel Medical Center. Thank you very much. The most important thing that I can say today for myself as well as all of the docs is that do not change any aspect of your medical care until you consult your physician. Only your doctor, truly only your doctor, can take care of you the way you are supposed to be taken care of and help you to improve your health. All righty. So, and also, yeah, let me not forget, I would like to thank OBHealthy for allowing us to bring you this webinar. Understand that they have their new app out, and the app is free with the code. And if you put in the code 365, it's a wellness app that has videos, health videos. It's a eating healthy as well as a weight loss and a whole weight loss program and meals plan. So download the app for free. It's all there for you.
So that's one thought.
I'm sorry?
Just one thought. So
Yes. Go ahead, Dr. Court.
Even though the booster has been beating me up today, please take the booster. It's important, right? As I told you earlier today, it's whipping me, but I can fight it.
That's Dr. Court. He's letting you know that he had the booster yesterday.
So did I.
Oh my goodness! So we have two of them. All right then.
Yeah, I got my booster about a month ago. You know, for 2 hours it took me down, but you know, we'll get over it.
Yeah, well, I'm the same. I got it about 3 weeks ago, and for that second 24 hours, I was a little achy there, but it passed, and I'm going forward. All righty.
I just came from the gym doing my exercises, so it didn't keep me down.
It didn't keep you down at all. See, but you're a spry 7-year-old.
And just remember, it's flu season, so we should also consider.
Oh, I got my flu shot too,
yeah.
about a month ago.
Yeah, it's important. It's very important. All righty. So let's tackle this problem that of pulmonary hypertension. It's one that and this is one of those diseases that is very difficult. Number one, in a sense that we don't have great medication for it. But it's one that can be devastating if it is in a severe state. Understand what is pulmonary hypertension. Now, let me just go through the chambers of the heart just for a minute. When blood comes back from the body through the venous system or the veins, that blood has already given up its oxygen to the organs of the body, and it's coming back to the heart to reoxygenate or to grab oxygen again. it comes back into the right atrium. And the right atrium is that small chamber on the right side. And then through a valve, it goes through, and then it goes into the right ventricle. And in the at the right ventricle, from there, believe it or not, the blood comes out of the heart and goes into the lung system. And they're called the pulmonary arteries that the blood will go into, going into the lung system at that time. Now, understand the right side of the heart is a very low pressure system. There should not be any true back pressure for the blood coming out of that right ventricle chamber into the vessels of the lung. With pulmonary hypertension, for some reason, and sometimes we don't know the cause of it, but many times we do, and I will give you some of those secondary diseases that cause it, there is a pressure that builds up in the lung system that prevents that blood flow from the right ventricle into the lungs to flow easily. And there's a resistance of that blood going into the lungs. Now, understand the right side of the heart is a very low pressure system, and it doesn't have a lot of muscle to push the blood into the lungs. So it should be no resistance to that blood going into the lungs. What occurs once the blood's in the lungs is that when we breathe in and we take a deep breath in, the lung tissue stretches to accept the volume of air for our height, weight, size, sex, and age. And a certain volume we should be able to breathe in. During that, what actually happens is that oxygen that's in that air that's in the lung has to diffuse across a very thin membrane to get into the bloodstream so it can attach to red blood cells and carry oxygenated or red blood cells that have oxygen now off to the body. But there are some diseases that inhibit that function, and there are some diseases that inhibit that blood flow from the right ventricle into the lungs as well. That's that pressure, that back pressure or that bottleneck. It's like a traffic jam. When you're driving down the street, and if there's a traffic jam, everything backs up. And that's what happens with pulmonary hypertension. There is high blood pressure that occurs in the lung system for many reasons. And we'll talk about some of the diagnosis. Dr. Atherley, do you want to chime in here? Maybe hopefully I explained it in a way that people can truly understand it.
Omar, I just want to take it a little bit earlier, which is the circulation of the fetus.
Okay.
So when a woman is pregnant, understand that fetus, the baby that's in the womb, isn't breathing. So they don't have air that's going in and out of the lungs. And the blood circulation is not the same before the baby is born and after the baby is born. And so what happens is that before the baby is born, there's a very high pulmonary vascular resistance. That means that those blood vessels that are supposed to be open to carry blood to the lung, since there's no air in the lung, they're extremely, extremely tight. And they're so tight that it doesn't really allow blood flow to the lung, which is okay.
You're talking about the baby now.
The fetus, that's correct. Right. And so the blood that returns to the heart, that returns to the right atrium, crosses to the left atrium, and then goes down, and then the blood that's supposed to be going to the lung just shoots up through the pulmonary artery into the aorta, giving not so much oxygenated blood, because the oxygen that the baby has is coming from the mother's placenta and already has a certain amount of oxygen from there. And so some of the problems that babies may be born with that have murmurs are the continued opening of that connection between the pulmonary artery and the aorta. And sometimes the connection between those two atriums that closes off doesn't close off. And sometimes that opening that closed off after a period of time can open. And Dr. Atherley can sort of explain some of those things. But I just wanted to give people an understanding that pulmonary hypertension, if you will, that is normal in before the baby is born. After the baby is born, that vascular resistance decreases dramatically, which allows for the blood, when the baby takes that first breath, allows for the blood to start to flow again. And that circulation changes just like that.
And it's amazing to think about that as well. Yeah. Dr. Atherley, can you help us out with that?
Just to mention some of the causes of pulmonary hypertension that we try to invest. Always when we try to treat a problem, we try to see if we can determine the initial cause first, then we see the manifestations of it, and then we decide on the best method of approach to treat them. So the right side of the heart sometimes functions almost as though it's an independent entity from the left. However, there's obviously a communication through the lungs, not normally. The pressure on the left side of the heart may allow, through its abnormal functioning, may allow increased pressure through the lungs, through the vascular or blood supply to the lungs and from the lungs, and that pressure may back up and affect the right side of the heart. So one of the causes of pulmonary hypertension may indeed be problems with the left side of the heart. Another cause may be embolization, and we've mentioned embolization back and forth, but that is clots going through the vein system backwards through those large veins to the right side of the heart, through the arteries from the right side into the lungs, and causing a backup of pressure in the right side of the heart. But then, of course, the one that really puzzles us is the pulmonary hypertension, where we cannot easily find a cause. We cannot easily see an indication of what brought this about in the first place. So our approach may depend upon what we see as the cause. However, in the majority of patients of so-called primary pulmonary hypertension, where we can't find it's not secondary to something else, we are then faced with the manifestations which occur and the difficult task of treating the patients. Shortness of breath is probably the commonest manifestation. Next to that, we see fatigue, tiredness, dizziness, again, a number of fairly non-specific findings. We see swelling of the legs because the fluid that normally would come back through the vein system to the right side of the heart. Now there's a backup not only of pressure, but of the volume of the actual return of blood. So these patients may have distension or dilatation of the veins that would return the blood, and hence a exuding of fluid into the tissues. And we see edema or swelling because of fluid in those tissues in the lower extremities. So there are multiple causes of pulmonary hypertension, and our treatments are far from perfect. The treatment for the primary pulmonary hypertension relates to trying to see if we can find a cause and treat it. I will tell you that we look now at the muscle in the arteries that go from the right side, from the right ventricle, as we call it, to the lungs. And these muscles are thickened in these arteries. So there are some medications aimed at trying to restore function and size of those arteries. And these are some of the newer ways that we may approach it. Indeed, one of the medications that has been used to chemically affect the growth of the muscle in these arteries is something that familiarly is called Viagra. So that is also used for some forms of pulmonary hypertension.
Just in terms of pulmonary hypertension, as I indicated before, before the baby is born, there's extremely high pulmonary vascular resistance. Under normal circumstances, the volume of blood leaving each ventricle, going to the lungs and going to the rest of the body is the same. And so when a baby is born, if there's a connection, a hole between the two lower ventricles, with the high pulmonary vascular resistance, there may be equal flow to each of the lungs. But as that vascular resistance starts to decline, there will be a murmur created as some of the blood that is in the left ventricle that's supposed to just go to the aorta goes into the right ventricle and goes to the lung. That means that the lung now is going to be receiving more than half the blood volume, and the blood that's going to the rest of the body is actually going to be less. That increased blood volume in the lungs is going to lead to pulmonary hypertension. And that's why there's a window that if someone has this defect or this hole between the right and the left ventricle, that be corrected. Because if it's not corrected over time, that increased blood pressure that's in the lungs, the pulmonary hypertension will become persistent. And those vessels, the muscles in those pulmonary arteries and the tributaries will start to increase. And at a certain point, you can't fix it. So if it's important that if someone has a ventricular septal defect, a hole between the ventricles, and has pulmonary hypertension, they have to get that corrected within the first 3 years of life. If they don't, then it may become irreversible and it'll just become progressive. And then that hypertension will ultimately decrease the volume of blood going to the lungs, and ultimately that will cause some compromise in their lives probably before 20 years.
We are fortunate that some of these small holes between the ventricles, or these powerful pumping chambers, left and right, some of these small holes close spontaneously, so we're fortunate in that regard. But certainly if you make the diagnosis early enough, we may have to be forced into treating them surgically. But also remember that there are holes between the upper chambers as well, between the atrial septal defects may also allow blood that normally would be restricted to the left side of the heart to get through to the right side through these holes in the upper chambers. So yes, that's another one of the potential causes of pulmonary hypertension.
Yeah. And I know we're getting technical, but one of the ones that from a pulmonary standpoint and patients on ventilators is the right heart pressure increasing to the point where the foraminal valley, which Dr. Sprott, closes once as a child, reopens, and you get that shunt from the right side to the left side, and that blood is not oxygenated at all, and then it's hard for us to bring the oxygen up with these patients, and it's a very difficult problem to treat. I'd just like to also talk about, as far as pulmonary hypertension, some of the causes that, one of the causes that's a grave concern is obstructive sleep apnea. And you would say, why would, number one, we should say, what is obstructive sleep apnea? Obstructive sleep apnea is during nighttime while you're sleeping, you actually stop breathing for various reasons. There is something called mechanical obstructive sleep apnea, but also central obstructive sleep apnea. The central is fairly rare. But the other, what actually happens is that you actually, during a stage, one of the stages of sleep, you actually stop breathing, and the oxygen in your blood decreases dramatically. And the brain realizes that you're not breathing and your oxygen is very, very low, and it actually snaps you back to consciousness or near consciousness so that you start breathing again. If this happens over a long period of time, several years, then it affects the heart. And the right side of the heart is affected, as well as one of the primary causes of pulmonary hypertension, because that decrease in oxygen over time affects the heart to the point that the heart is, it decreases its function. Maybe Dr. Atherley can talk a little bit more about that. But that obstructive sleep apnea is usually associated with obesity or being overweight. And one of the primary treatments for obstructive sleep apnea is weight loss. And there are other treatments that are palliatives, what's called CPAP machines. And basically what the CPAP does is it causes a gentle positive pressure to the back of the throat as you sleep with the mask. And it allows that area of the throat that usually collapses down, not to collapse down, and allows you to continue to breathe as you sleep during the night. Other causes of pulmonary hypertension, understand that there are things like interstitial lung disease. And what is that? That's when there's a scarring on the lung. And because the lung is scarred, those vessels, as it goes through the lung, usually they go along nice and smoothly. But if the tissues are scarred, and basically what happens is those vessels start kinking, and that causes that back pressure. And also, if that tissue is scarred, the membrane that I talked about earlier, that the oxygen has to diffuse across to get from the lung that oxygen into the bloodstream, that tissue becomes thicker. And obviously that diffusion is more difficult. So even though the lung may be bringing in plenty of air with oxygen, that oxygen is having a hard time going across that membrane, getting into the bloodstream, and your oxygen in your blood is lower. The other thing is there are things like sickle cell disease that may cause, because of scarring on the lung, may cause pulmonary hypertension, and things like lupus and connective tissue diseases. Even severe arthritis can cause scarring on the lung that may cause pulmonary hypertension. Alrighty.
One point about the obstructive sleep apnea. We always think of pulmonary disease and sleep apnea as affecting the right side of the heart, as we were emphasizing the role in pulmonary hypertension. It's important to recognize that obstructive sleep apnea is also associated with diseases involving the left side of the heart, especially just regular hypertension and resistant hypertension. That is hypertension or high blood pressure that is difficult to treat, that does not respond readily to the usual approaches that we have. In a large percentage of patients who have resistant hypertension, we find that obstructive sleep apnea is present. We've also found a relationship between obstructive sleep apnea and coronary artery blockages, between obstructive sleep apnea and congestive heart failure. That is increased weakness of the left side of the heart, so that the left side does not pump effectively, allowing fluid to back up in the lungs and fluid to back up elsewhere. That is also related to obstructive sleep apnea. So as we look more closely, we find obstructive sleep apnea is involved in a diverse number of other medical and left-sided cardiac problems, even strokes. There's a relationship with obstructive sleep apnea.
I just like to talk about the definition of apnea. When Omar talked about a pause, if you think about, I'll just say a normal adult, they may be breathing, and this is going to be my example, 15 breaths a minute. If you're talking about a minute, that you're talking about a cycle that's going to last about every 3 seconds. And so what happens during that 3 seconds is you breathe air in less than a second, and then you breathe air out, and it takes a little longer to breathe air out. And then there's a pause that occurs before you take another breath. And during that pause, where you're not really breathing, your carbon dioxide is increasing. And as your carbon dioxide increases, the oxygen in your blood decreases. That increase in carbon dioxide can also lead to an accumulation of acid. And so the combination of the increase in the carbon dioxide, an increase in acid, and a decrease in the oxygenation can cause the vessels in the lungs to constrict, causing pulmonary hypertension. And when we talk about apnea, so we're talking about a pause or an absence of breathing. Remember, we're talking about a cycle that's sort of every 3 seconds or so. You're talking about an absence of breathing for 15 or 18 seconds, a long, long pause. And very often the stimulus for your breathing, remember I said the cycle is 3 seconds, is a very, very tiny rise in carbon dioxide. That's a more important stimulus to breathe than is a decrease in oxygenation. And so that small increase in carbon dioxide tells the brain to breathe. When you have that long a pause, it's a long, but still it kicks in the brain. And if you're in a position where you can't breathe, brain will say change position so that you can start to breathe. But very often there'll be snoring and noises that are made with this. And so it becomes very important that if people have obstructive sleep apnea, to use that machine, that CPAP is continuous positive airway pressure that keeps the airway between the throat and your trachea open and allows you to breathe without having that obstruction or the interruption. The other thing it plays havoc with, if you have sleep apnea, is your ability to have quiet, peaceful, restorative sleep. And so the people who have sleep apnea usually wake up, they're still tired because they haven't had restful sleep because they've been bouncing all over the place. So I think it's very, very important. And again, Omar talked about the issue of obesity and diet, that most of the people that have this issue of obesity can have improvement in their sleep apnea if they lose weight.
Excellent, excellent. Let's get to some of the questions that's come in, because we have excellent questions coming in. Does the color of the whites in your eyes indicate anything, i.e., if they are reddish or yellow? All righty. Well, let me start it off. As far as reddish is concerned, you worry about things like, is there an allergy, or are you itchy, or do you have itchy eyes from some type of an allergic reaction? Number one. Number two is there's some type of infection. Sometimes you can get a viral infection that causes areas of the eye to become very red. And as far as yellow is concerned, what we worry about is some type of liver disease that may be associated with the increased bilirubin and things like that, that may turn your eyes yellow. Anybody else want to chime in on this one?
Yeah, I think that you're right. I mean, in babies, very often in babies have an issue of jaundice, that yellow pigment in their eyes and also in their skin. And very often it might be exacerbated by breastfeeding. And so in normal circumstances, when babies are first born, they get checked to see if the bilirubin is elevated. And sometimes they might need to have what's called a Billy light, or a special light that helps to convert that bilirubin from being harmful, because that kind of bilirubin that's elevated can cause damage to the brain. And so it is important. And there, in addition to, that redness to the eye, that we sometimes call it conjunctivitis, because the layer of tissue, both on the eyeball and on the inner lid, can become inflamed or irritated. And it could be allergic. It could be, as Omar said, it could be a viral or bacterial type of conjunctivitis. Again, with newborns, we actually put something in the eye to kill germs that might have picked up through the birth canal, to prevent things like a gonococcal or gonorrhea can cause an infection of the baby's eye that they all get treated for. And then with certain individuals, they can have bleeding under the conjunctiva. And that you can see, it almost looks like a monster. You have this fiery red that covers the entire eyeball, and it's usually not harmful at all. It goes away as soon as the blood goes away. And some people that sneeze or cough might have that subconjunctival hemorrhage. But that's from the pediatrician standpoint, those are the common things that we're concerned with either yellow or with red.
Right. Yeah.
Can I ask Dr. Athley a question?
Yeah, surely. Sure.
So let me give you a common scenario, which you'll probably get a couple times a week. And that's the patient who comes in and the nurse tells you she or he is here for cardiac clearance. So they're going to undergo some procedure and they need cardiac clearance. If you could walk us through the thought processes that would go through that situation.
Okay. Fair enough. Essentially, what we're asked at that point is to determine the patient's risk of undergoing anesthesia and surgery. So we go through a number of checkpoints fairly quickly, and there are a few specific calculators, for example, the revised Lee calculation, to determine whether the patient may be placed at low, moderate, or high risk of having adverse effects on the heart and vascular system if they're subject to anesthesia and to surgery. So what are the factors we look at? We look at, first of all, the kind of surgery, whether it can be classified as major or minor surgery, whether it involves a major area such as the brain or in the abdominal cavity, or is it just of the periphery of the knee or back or something else. We look at the kind of surgery. We look at the patient's intrinsic processes. Does the patient have congestive heart failure? Is there documentation of the heart being weak? Has the patient had a stroke? Does the patient have diabetes, or not just diabetes, but insulin-dependent diabetes? What is the patient's age? Does the patient have coronary artery disease manifested by previous heart attack or blocked arteries which were treated with stents or otherwise documented clearly? When we put these factors together, we then can quantify the patient's risk and determine whether or not there is likely to be an adverse effect in the short period after surgery. Then we send the information to the surgeon record, and he will decide. I've had patients whom I felt were at acceptable but high risk for surgery, refused by the surgeon because he said, I'm not prepared to take a high risk. One of the areas in which we commonly are asked to clear patients is for surgery for obesity, for example. Many times the surgeon is reluctant to perform bariatric surgery for obese patients if we find enough risk to categorize them in more than moderate risk for surgery. So yes, we work in concert with the surgeon. We advise what we consider the cardiac risk, but the final answer is always the surgeon as to whether or not he's prepared to take that risk in performing the surgery on the patient.
Right.
I'd also like to add, Trevor, that as important as the surgeon is the anesthesiologist, because they're the person who has to put them to sleep, and they want to make sure that they wake up. And the surgeon wants that to happen too. But it's usually the anesthesiologist, in my experience, that is most concerned about whether or not they can stand the ability to undergo the anesthetic, and partly related to how long the anesthesia has to be given is related to the difficulty of the surgery or how long it's going to take.
I also think, with clearance, we're not necessarily asking Dr. Atherley to say, go ahead, this patient is going to do fine from a cardiopulmonary perspective. But the advice he actually gives us allows us to prepare. Prepare for the stress of the surgery and the patient, put in place all the cardiovascular technical support that we need during the operation in terms of the type of anesthesia, the type of anesthesiologist, whether it's a cardiac anesthesiologist, the type of, even down to the type of ventilators that we'll use. And then after surgery, where does this patient is best served? Do they recover in recovery room and then to the ICU, or go directly from the operating room to the ICU? And then in the ICU, what are the type of monitors that we need to have available to adequately resuscitate this patient from a cardiopulmonary perspective?
Yeah,
and I'd like to add that the preparation starts before the actual surgery, of course.
Correct.
We're often asked to optimize the patient's cardiac status. And by that I mean get the patient in the best heart shape. So increase or improve whatever medication we're doing. If the patient's volume overloaded, too much fluid in the body, get rid of that, et cetera, and do what we can to improve or optimize, have the patient in the best possible shape so that the surgeon and the anesthesiologist may then be able to perform adequately.
Yeah.
Right.
And sometimes we have to ask the question is, why did Dr. Clark ask this question? Because sometimes what we do is we know we're looking at a patient who we know if we can get them through an operation and through the perioperative or the recovery phase, the subsequent treatment for the problem we want to operate on, once that's resolved, their quality of life is good. So we also prior to sending a patient to Dr. Atherley for evaluation, we evaluate what we call their performance status. And that's usually an indication as to, well, if this is the baseline, will our intervention get them to a better place? Mm-hmm. And with the support from the cardiopulmonary perspective, will that help us get them through the operation and through that perioperative period? And it also helps us to see how radical we can be in the operation, because that's where some of the most compromising decision making occur. Help me here, Kevin, because sometimes we operate on tumors and it's in a location where, for lack of a better term, a younger patient can tolerate the stress of the extra blood loss, tolerate the stress of the extra dissection, and tolerate some of the potential complication of going the extra distance compared to doing what we call a minimal intervention. So when Dr. Atherley said severe risk, moderate risk, and so on, it helps us decide how much risk we can take surgically.
Right. I think the term cardiac clearance, and I used it because that's what's commonly used, is actually incorrect. It's risk stratification,
correct,
and optimization, which is what we want to hear.
Right.
You're absolutely right about the decision, and it helps us to counsel the patient, because it's not so much, a big part of it is the surgeon taking the risk, but the patient has to understand what their overall risk is given the context of what the proposed procedure is. So in our situation, we're typically dealing with tumors, and it's in the context of potentially doing something curative. So you have to balance doing an operation in a possibly compromised patient, and you don't want to match the treatment to the patient, right? You always want to match the patient to the treatment. And when I say that, there are patients who you can do a curative operation, but are at prohibitive cardiac risk. And the alternative, although not as good on paper, probably for that particular patient is the most appropriate thing. So as opposed to doing a big operation, you treat them with chemotherapy or radiation. So that helps us to kind of gauge how we treat those patients.
Yeah, and I know that you're talking about clearance from a cardiac point of view, but from a pulmonary standpoint, we have to clear as well. And what we use is I should say, chest X-ray and pulmonary function tests. It's important for the anesthesiologist, I think, as Dr. Sprock stated, because he has to continuous during the surgery, he has to allow the patient to oxygenate, meaning that he has to deliver appropriate oxygen to this patient and keep the blood pressure stable during this during the surgery from the beginning to the end. What we do is we actually evaluate three things on the pulmonary function test. We evaluate how open the airways are, whether the airways are in spasm, or is there any chronic decrease in flow in the airways, secondary to many types of diseases. Number two is the volume of air that can go into the lung. Does the patient have scarring on the lung that will not allow it to expand to take in the appropriate amount of air to get the oxygen into the bloodstream? And then the third thing is called the diffusion. And I talked to this earlier. Once the air is in the lung, the ability of the oxygen to go across that fine membrane and get into the bloodstream, is that compromised? And then chest X-ray, obviously, to show us, is there any structural changes that may be concerning that we need to let the anesthesiologist and the surgeon know about. All righty. Let's go for another question. This question, it's a little over my head, but let's see. Are you familiar with nattokinase as a alternative blood thinner? And is it as effective as conventional blood thinners like Coumadin? Are you familiar with it at all, Dr. Atherley?
I think it may be extracted from soy products. I've heard of it in digestive diseases, etc. I know that it has been tried in high blood pressure, as have many natural medicines being used. It's been tried in high blood pressure and also in deep venous thrombosis, that is clots in the lower extremities, without, to my knowledge, scientific documentation of clear-cut benefit. So I've heard of it, but I am not in a position to recommend it because I'm not aware of any scientific studies which document its value in cardiovascular disease.
Okay, thank you very much. The next question is someone excellent. Thank you. And it says, thanks, please encourage people to have a regular visit to their cardiologist. All right.
Here.
I agree with that 100%. There we go. This one is for Dr. Atherley. If the ejection fraction improves to over 35% from 20%, can someone with an implanted cardiac device successfully have the ICD removed?
Interesting question. This patient obviously is quite knowledgeable in terms of these factors. I have no option but to explain what these terminologies do refer to. First of all, the ejection fraction is a measure of the strength of the heart muscle, specifically of the left ventricle, or the most powerful pumping chamber of the heart. This is the last chamber that the blood is in before it goes out to the rest of the body. So a measurement of that is most often used to suggest the strength of the heart. Now, the normal value, he mentions 20 and 35 as two numbers he's thrown out. The normal value is, depending on how you measure it, more than 55%. That is, when the muscle squeezes the blood out, it doesn't empty totally. It does not squeeze all of the blood out, but it can squeeze about 55% or more of the blood that is contained in that chamber out to the rest of the body to do its work. That would be considered normal. Now, when the level falls significantly, there are some complications and consequences. When the level falls below 35, which is the number he's quoted, that has been demonstrated in many studies to have the patient placed at high risk for lethal irregular heartbeats, lethal arrhythmias. So not only is it documenting that the heart muscle is weak, but what it is suggesting is that that weakened muscle may be subject to some very severe and potentially lethal irregular heartbeats. So what we have done in the past, and still currently, what we do is place a specific device called an ICD, an internal cardiovascular defibrillator, cardiac defibrillator, which can sense what the patient's heart is doing electrically. And if indeed it detects that they're having these kinds of irregular beats, sustained or continued irregular beats from the lower chambers, what we call VTAC, ventricular tachycardia, or worse, ventricular fibrillation, which untreated is lethal. What can happen if the device is able to detect the presence or the occurrence of these is that it can deliver a shock to the patient, or it can rapidly pace the patient as an alternative, but it essentially, ultimately, would be a shock to the patient from inside, so as to jolt the heart back into a nice regular rhythm. The discriminating ejection fraction that we have utilized based upon a lot of, some conjecture, but based upon a lot of investigational experience, is that when that level of 35% is reached, that's when the chances are high of having this terminal or potentially terminal irregularity occur. Now, what we have found is that we don't usually, when the diagnosis is first made, put that device in, but instead we observe the patient for a period of sometimes up to 3 months on optimal, that is, on the best medication available, optimal medication. And in many instances, we see the heart muscle improve in strength. So it goes above that 35% level. And then we decide, well, we no longer need to consider the ICD or the defibrillator. In many instances, of course, it does not improve. And so we are forced into then putting the defibrillator, but we don't put it initially. What I am seeing more and more of is that the long-term improvement in some of these patients does indeed put them at a level where we consider them no longer at risk. So this patient may have had a device in for a lengthy enough period to be observed and repeatedly found that the ejection fraction, the number, is now high enough that he would not have qualified initially for the placement of the device. But the question is, what do you do? You've already got the device in there. It is a safeguard which is in there. It does not harm the patient once it's working effectively. It is like a pacemaker sitting quietly and detecting if the person's heart needs it. If they need it by virtue of the irregular beats. If they don't need it, then it's just their device which is sensing what the heart is doing electrically, but laying quiet and not doing anything. So yes, it is possible, in answer to the specific question, it is possible to remove that. It does entail sometimes some difficulty depending upon how long the leads have been in the heart. Essentially, I would say that there are leads which are passed through the vein back towards the heart, and they're connected to the device which is placed under the clavicle, that's near the collarbone. So it is possible easily to remove the part of the device that's under the collarbone, but removing the leads can sometimes be a little tricky. And we have to wonder if the device is functioning adequately and not causing the patient any problems, if it's worth it to do that. So the technical answer to the question is yes, it is possible. But the other question is really, is it necessary, or can we leave it and continue to observe the patient if no harm is being caused?
Trevor, I'm not a cardiologist, but you start out by saying that normal is 55%.
Yeah.
So something happened. Let's assume that she was normal at one point, and she went from 55% to 20%. She's now only up to 35%. She's not near normal. Is there any likelihood that she's going to continue towards 55%? on her own?
Possibility, not likelihood. Possibility.
So she's not normal. I would think that there's some possibility that she could still go back in the other direction.
It's a very good point.
And so I would think, you know, if it were me, I'd leave well enough alone.
Fair enough. I think that in the question of whether or not there is an actual clinical indication, an indication for having the device in, one may argue, rather than supposing that it may go back down, may fall again to that level, one may argue that the patient is above the required level and therefore does not, in fact, need the pacemaker. But your point is very well taken, that it depends on the kind of heart problem that the patient has had. And it is certainly possible. For example, if it was a heart attack that initially caused the problem, weakened the heart, it's possible the patient could have another heart attack in the future, and then the heart become even more weakened, despite the initial improvement. So these are all possible. Secondly, this major improvement in ejection fraction has been by and large a credit to some of the newer drugs that we've been using for weakened hearts. And there are one or two in particular that we've seen with great success improving the patient's hearts to a good and appropriate level. But I will grant you that most times we do not get back to a normal level. We get to an improved level above that critical value, but not usually back to a normal level. I agree with you.
All righty. Excellent, excellent. And also I'm saying, I'm sure that there could be potential complications with removal of the ICD as well. So you have to take those into consideration as well. The next question. I've been having a lot of leg pain and cramps in my legs whenever I sit or stand for some time. I have been on blood pressure medications for some time as well. I also suffered from pre-eclampsia during all my pregnancies, and hence still is having elevated blood pressure. Could these symptoms be caused by blood pressure issues? All righty, so there's a lot there, but it centers around preeclampsia, also blood pressure, having issues with blood pressure on blood pressure medication. Just to start it off, yes, blood pressure medications can cause some cramping, that's for sure. There is one of the medications that are diuretic, or one that allows you to urinate the extra fluid off. And some of those medications decrease your potassium, maybe even your magnesium, and that has to be replaced appropriately. If not replaced, definitely you can have weakness and you can have cramps. And that's one of the things that your primary care doctor should investigate. Can we have some others chime in on this? Because there are several aspects of this that I think we can talk about.
Yes, Omar, we know that some of the issues that patient encounters during pregnancy is an indication as to what will happen to them later on in life. We know that, for example, while pregnancy is a diabetogenic state, meaning there are issues with elevated blood sugars and so on, patients who develop gestational diabetes are very likely to become diabetics as they get older. This is the same issue. Patients who become preeclamptic during pregnancy are also at risk for developing chronic hypertension.
Patrick, can you explain what preeclampsia is?
Right, I had alluded to this before. Preeclampsia is a hypertensive disorder of pregnancy that's associated with elevation in the blood pressure, oftentimes to what we call hypertensive emergency levels. It's associated with some neurologic changes, increase in tremors, what we call hyperreflexia. It can affect the kidneys, where we see patients spilling protein in the urine. And when they become eclamptic, they can actually have liver dysfunction and have seizure disorders. So in that setting, these patients themselves are at risk for developing chronic hypertension. Now, depending on how old this caller is and how the age at which she had her children, that could demonstrate some time element there for which this condition exists. And some of the cramping may also be related to poor circulation, to put it loosely, or what we call peripheral vascular disease. And hence, with increased activity, and increase oxygen demand to the muscle of the extremities and diminish return because of poor circulation. They could be getting what we call claudication or cramping in the legs.
The hypertension associated with preeclampsia and eclampsia, usually, if it's high enough, one of the things is to deliver the baby, because this is around the time that the baby is born. And usually after delivery, things tend to get better. The pressure may stay up, but usually that hypertension doesn't persist. It usually eventually goes down. I don't know what her baseline might have been prior to that, but usually if it's just associated with the pregnancy, after the delivery, it tends to return to her baseline.
Yeah, Dr. Spark is absolutely right. It's usually transient and usually goes away after delivery. However, the fact that they develop preeclampsia, many of those patients are at risk for developing hypertension later on in life.
Right. Okay, excellent, excellent. I'm just going through some of the questions here. I want to cover a question that I think one of the doctors has answered already. It says pancreatic cancer, when diagnosed, is usually in advanced stages. What are early signs and that could help diagnose sooner? And I think that's I think that's worth going over. Kevin, can you start that off a little bit, please?
Sure. First off, unfortunately, there's no early signs of pancreatic cancer. Most of the signs and symptoms end up being similar to other conditions. So ulcer disease, irritable bowel syndrome, dyspepsia, all these things, stomach upset, they're all, the symptomatology is all similar. And it's not a situation where, unfortunately, we can pick it up at an early stage, unless we have a particular indication that an individual is at high risk. So unfortunately, the majority of cases are picked up when they're symptomatic, and that's abdominal, epigastric, or back pain, weight loss, or new onset jaundice. One of the other things also is new onset adult diabetes is an indication, or could be a manifestation of pancreatic cancer. Now, there are certain situations if there's a family history or if there's a known mutation, we do screen those patients a little bit different. So if there's a family history of pancreatic cancer, you will undergo interval screening protocols with a CT scan to see if we could pick up the lesion early. But unfortunately, at this point, I should say at least, there's no biomarker or blood tests or tests that we can use to predict whether or not you're going to get pancreatic cancer, or to predict the early onset, like how we have with some other cancers.
Excellent. Thank you very much. There's a question that came through. It says, I have a warmth on one side of my calf. Heard it might be nerve issue. I have spinal stenosis. I am 85. Any comment and about what I may do or can do about it? All righty. I know Dr. Court stepped away. He must be with the kitty. But I do know as far as spinal stenosis is concerned and sciatica, you can have neurological symptoms of your lower extremities. That's for sure. What we can do about it, I know that different exercises may help. Physicians such as physical therapy is important, and as well as possibly a chiropractor may be able to help as well, either diagnose or administer appropriate therapy. Anyone else can chime in on this one? I know our internal medicine doc stepped away.
Well, just a little bit about sciatica is sort of, usually it's pain associated with the nerve that is mechanically usually has pressure on it at some point in the back or pelvic area. And there are certain kinds of stretching exercises that you can do, and you can actually try them and if you go online and you can look at various positions that you might use to try and relieve that pressure, and they work. And sometimes it's quite dramatic and it's quite quick if you have the pain on one side. If one of the things that you possibly could do is again, he's 85. I don't know how flexible they may or may not be, but to create a stretch by taking the foot, bringing it up, and pulling, which stretches at the hip. And you can do it with either side, depending upon where it is, or both sides. And sometimes, if you do that, it's fairly dramatic as to how quickly it goes away. But I think that if he went to a physical therapist at the direction of the doctor, they could figure out which might work for that individual. At times, with spinal stenosis, some people recommend surgery. The issue with surgery is, you got some of the same kind of issues. But anytime you're talking about surgery on the back, there are three possibilities. Either it gets better, it stays the same, or it gets worse. And so, and when you go to your doctor, and it could be an orthopedic doctor, or it could be a neurosurgeon that you go to. Sometimes there are other folks that are involved. The rehab specialists, sometimes they do injections and things like that. And so and sometimes the interventional radiologists get involved. So there are a whole lot of different doctors who you might be able to approach as it relates to pain. When you talk about injectables, the injectables might be either just for pain, or it could be steroids. And again, they're not curative, because they just sort of relieve the pain associated with a particular point, but it doesn't change the dynamics of what the anatomy is, or what's causing the impingement. And so I think that before you go to someone that wants to cut on you, you need to kind of understand that they're likely not going to be any guarantees that if you have it, it's going to definitely get better. It may not.
Excellent. There are three that I would like to get to questions. So I'm going to start with the first one, and we're going to go through it because our time is coming towards an end. And this is one that it says, I am a 24-year-old Black male diagnosed with hypertension about 3 months ago. I have changed my diet and exercise more. I'm down 22 pounds. Whoa, that's impressive in that short of time. Since being diagnosed, I have decreased my salt intake tremendously. My goal is to come off the medications which was prescribed. My pressure has come down, but remains borderline high. And I can say that this is one of the this statement actually is saying that this person, this young man, 24, is definitely in the right direction as far as improving his blood pressure and getting it to a point that possibly in the future he may be able to come off. Anybody has any thing to chime in as far as this one's concerned?
Yeah, this is a young adult, and I think that it's important when you talk about how in a young adult or adolescents, which they may have developed hypertension, that the diagnosis be made in an appropriate manner. A lot of times when kids or young adults go to the physician's office, they may be anxious. They may have some elevation in their blood pressure because of that anxiety. The important thing, especially I'll say an assumption on my part, that this young adult was overweight, maybe obese, that they use the right size cuff. When you do a blood pressure cuff and you use the arm, it needs to be at least 2/3 of the upper part of the arm. If the blood cuff is a normal blood cuff and this arm is large, there'll be a false elevation in the blood pressure. So it needs to be the right size cuff, and then it needs to be done on at least 3 occasions with the individual calm and comfortable. And ideally, if they have a blood pressure machine that has the right size cuff, they can do it several times a day. And so what you're looking for, if it's a physician going to the physician's office making the diagnosis, at least 3 episodes, maybe over a 3-week period, that shows an elevation related to this individual. And you know, Dr. Court can tell you that what's considered normal in pediatrics is related to the age and sometimes some of the biometrics or the height and weight of the individual. But I think, you know, it's 22 pounds in 3 weeks is a little over 7 pounds a week, which is it's usually not all the weight. A lot of times that can be water weight, but it's not usually related to fat. But indeed, if indeed he were to get to, I'll say, again, we don't have the initial starting of an ideal body weight that has, you know, a nutritionist that talks about this, as well as someone that you know, can advise him on the proper exercise and all. Number one, you know, I'm not so sure about the diagnosis in terms of it's being made properly or not. It may have, but I think it'd be important to sort of, most importantly, for him to monitor his blood pressure on a daily basis. If he's got something that's a chronic disease, and he's looking to do that, if he were able to create a diary that shows his blood pressure is within normal limits for his age, his height, and his weight, then it may be that the doctor might say, oh, well, he really doesn't have hypertension. And the question is whether or not he did, if that's the case. But I think that would be the way to start, creating a diary, and then you can bring that to the physician and say, here's what my blood pressure has been. I've been using this cuff. I've been doing it on a regular basis, and here is sort of a graph of where my pressure has been.
Oh, this is a young one, soundingly highly motivated individual since he's lost weight quickly, etc. So I would think there's a potential for him to get off of medication, but he has to achieve all of the appropriate measurements as were being alluded to by Dr. Scott. You should know what his blood pressure is expected to be. You should try to achieve the ideal body weight, exercise adequately, and importantly, control other risk factors, because there's a continuum of combined risk factors in terms of one's overall risk. So control the high blood pressure, yes, but also be careful about his sugar and cholesterol, etc. Exercise adequately. So I would say, yes, there's a possibility, but he must maintain appropriate levels and demonstrate this over a period of time, and he may get off the medication.
Yeah, and another question for Trevor is, you know, with the COVID, and especially as it's affected our youth and young adults, what are some of the complications related to the heart as a consequence of COVID?
Oh my God. All right, if we have time to discuss those, I'd like to suggest that COVID has been related to disease of all aspects of the heart. Okay, if we start from the outside, the outer sac in which the heart fits is called the pericardium. And we've had COVID pericarditis well documented. That is an inflammation involving the pericardium with increased fluid. That's been seen. Myocarditis has been reported more frequently, and myocarditis is disease of the heart muscle. Again, an inflammatory process caused by the virus, and then maybe a reaction after that, a continued reaction after that, because we've seen in a small percentage of patients, there have been a few studies, one notable German study, for example, which show the significant but a minority proportion of individuals who had COVID with no documented heart disease during the time that it was acutely diagnosed, but later on follow-up, found to have, on very, very sensitive testing, some disease involving the heart muscle, a form of myocarditis or cardiomyopathy, the question of the potential development of weakened heart for the future. So that's the heart muscle. The arteries to the heart, we've seen, because it is a thrombotic disease now, COVID, and the manifestations, more venous thrombosis or thrombus in the veins, but we've seen also in some patients increased heart attacks. And during the height of the COVID, we saw that patients did worse with heart attacks because they tended not to come to COVID emergency rooms, come to the hospitals early and would present a little later. So we saw a lot more mortality with heart attacks. And we even saw the opposite, the people didn't come at all. And the documented myocardial infarction rate seemed to fall in emergency rooms, but patients died more at home. So there are a lot of overt and covert heart effects associated with COVID. I put that quickly in a nutshell, if you will.
All righty. What I'd like to do, and I promised that we would cover these, and so if we can extend it just for about 5 minutes more. Dr. Anderson, my middle age, for middle-aged female, 47 to 52, what can you do to alleviate some of the menopause symptoms such as hot flashes?
Well, the number one, just to be brief, way to manage hot flashes is with pharmaceuticals. And depending on the reproductive history with respect to surgery, whether the uterus is in place or not, the type of pharmaceutical you use, whether you use single agent with an estrogen, or double agent with estrogen and progesterone, which is essentially mimicking a cycle so you don't get unopposed estrogen use, then that could be one option. Then the other thing we need to consider is the menopausal symptom. Is it hot flashes, or is it things like bladder dysfunction, vaginal dryness? And then you have to consider underlying conditions, because some of these hormonal use can exacerbate or make certain conditions like clotting conditions worse. So in certain patients, you don't want to use certain medications. So then you have to look for alternatives. And some of those alternatives include lifestyle, for example, exercise. So it enables you to sleep better at night and not so have interrupted sleep from the hot flashes. There are certain natural compounds that you can use that has components we call phytoestrogens. Certain things as in soy products, black cohosh, wild yam roots. Those are some of the natural products that has a lot of these phytoestrogens or natural estrogens in them. There are certain medications where, when we use medications, we look for the effect, but sometimes this side effect can be useful. We talk about use of Viagra in pulmonary hypertension. We can use Viagra for other things. Certain blood pressure like minoxidil, which lowers the blood pressure, will cause hair growth. So the same thing here. So for example, certain neurologic drugs, for example, gabapentin, can help alleviate hot flashes, or Neurontin. We use that for neuropathic pain. Certain hypertensive medicines that act centrally. For example, Catapres, which is, I believe, remind me, Dr. Sprott, this is an alpha agonist, right? Has the side effect of alleviating hot flashes. So it depends on an individual's situation, which also include history of malignancies, history of prior heart attacks, history of high blood pressure. There are certain medications that can be used, certain medications which we cannot use. One would have to sit with a physician who can do a risk assessment and put it in perspective with the larger studies, the Women's Health Initiative studies, that look at postmenopausal women receiving hormones over a long period of time, combination hormonal therapy, and addressing the potential side effects, which not only includes stroke, heart attacks, but incidents of breast cancer, clotting events, and so on and so forth.
Excellent, excellent. And that's going to be the last question. Before we go, this is what I'd like to do. There are some statements that have come through. I think this is AH, states, "Thank you for your response. I appreciate all of you for your monthly input. God bless you all for the work that you're doing and continue to do, especially in our at-risk communities." All righty. The next one is from BL. It says, "Thank you. Excellent info." All righty. And then the last one is from JL. It says, "Thank you for another informative session. I benefited a lot." And there's an anonymous attendee that said, "Thank you all for your help." All righty, so we appreciate that immensely, letting us know that you appreciate what we do every second Saturday. And in closing, I'd like to thank OBHealthy for allowing us to bring this to you. And so appreciative that you came on and or come on and listen to us to increase your knowledge as far as your health is concerned. Remember their health app. Please go to OBHealthy and on your phone and download the app for free and use the code 365. Also, remember, every second Saturday we're here at 1 o'clock. Look to have you join us next time. It's all about caring and sharing. The most important thing that I can say, and I will keep saying this every time we have this webinar, is that do not change any aspect of your medical care until you consult your physician. Only your doctor can truly understand your medical problems and treat you appropriately. Thank you very much to all of the docs. Thank you to Dr. Court for trying to hang in there. Understand that he had his vaccine yesterday and he's feeling a little under the weather, so we understand that he had to leave us early, but that's okay. He came and he showed up. Thank you again, all, and we will see you next month, second Saturday, 1 o'clock. Be there or be square. All right. Peace, everyone.
All right. Bye-bye, everyone.
Bye-bye.
Bye, everyone.
Bye-bye.